need to go in a specific order. So we'll start by letting you know diabetes is a very common illness. These numbers are probably out of date. So you can see 12 million patients with type 2 diabetes in this country, 8 million who don't know they have diabetes, and about 1 million type 1 diabetics. The number might be up in the 24 million now, something like 3% of the population, expecting to expand to the year 2050, that about 40% of the population might have diabetes by the year 2050. I'll hopefully be retired by then and won't have to deal with all that diabetes, but somebody will have to deal with it. So this is the prevalence of diabetes in this country in 1994. The red states are the states that have, well actually the dark red have the most highest prevalence of diabetes, and the yellow states were the lowest. Notice that the deep south had most of the diabetes in those days, and a few Californians. I have a house in South Carolina. You can see I'd be busy if I actually wanted to work in South Carolina. This is 2004. Everybody should get up and move to Colorado now, because it's the only place that's safe to live. So the epidemic of diabetes is nationwide. It's those outdoors folks who hike and climb mountains and go cross-country skiing who prevent themselves from getting diabetes. And diabetes gets worse as you get older. Dr. Reichel is sitting here. I wrote a chapter in his textbook a long time ago, 20 years ago, something like that, about diabetes in the elderly. Well, it's become a bigger issue. We actually have in our practice a grant from Hopkins to study optimal diabetes therapy in the elderly. If you ever try to deal with a Hopkins IRB, you'll know that we've been trying to get this approved now for 9 months. We've had the money for 9 months, but take 9 months to get approval from the IRB to actually do the study. But hopefully we'll come to actually investigating what's the safest and best approach for patients over the age of 70, which we picked for this trial. Patients had to be older than I am because I'm 66. So I had to be younger than the patients at least. But you can see for diagnosed diabetes, undiagnosed diabetes, and impaired glucose tolerance, all of these go up dramatically as you age. And so we would expect, if you see this at age 75, 40% of the population has some abnormality in glucose tolerance. So it becomes almost a norm if you get to live long enough. So what is type 2 diabetes? What's the definition of type 2 diabetes? So it's worth knowing this because I think this comes around all the time. Type 2 diabetes is a metabolic disease characterized by hyperglycemia resulting from a combination of resistance to insulin action and an inadequate insulin secretory response. So to translate that into easier to understand terms, in patients with type 2 diabetes, you have insulin, your beta cells make insulin, but they don't make enough insulin to overcome the insulin resistance at target cells. And so even though you may have more insulin than somebody who's not diabetic, it's not working very well and the blood sugar goes up because you can't move glucose from your bloodstream into fat cells and muscle cells, and so the blood sugar just builds up. So this is sort of simplified. We now want to add more things to this. Type 2 diabetes involves two primary processes. The beta cell has to fail. If you take two identical people, overweight, sedentary, bad eating habits, bad lifestyle, but normal glucose, overweight, sedentary, same weight, same lousy lifestyle, but elevated glucose, this person's pancreas doesn't work, this person's pancreas can overcome all these bad things the patient does. So it takes two parts of this. Why the epidemic of type 2 diabetes in this country? It's not because the gene pool has changed. What has changed is the lifestyle. So this is environmental that's causing the increase in type 2 diabetes. It's lack of exercise, it's bad diet. So these are the important things. But we know that there are lots of other factors that play into this progressive decline in pancreatic islet cell function, and other factors that play into diminished tissue responses. This is sort of a simplified version. So I could show you a different slide which looks at 8 different inputs into these two factors. So when we look at treatments for diabetes, we can attack this from 8 different angles to try to make this work better. So what are our risk factors? Well, genetics. If both of your parents have type 2 diabetes, you will get type 2 diabetes. That's the way it goes. If only one of them has it, your odds are far less, but they're still pretty high. Ethnic groups have a higher incidence of diabetes. African Americans, Hispanics, South Asians, people from the Indian continent are much higher risk of getting diabetes. Age I showed you earlier on. So that you're stuck with, you know that. It doesn't mean you have to give in. You can't change your ethnicity, you can't change your genetics, but you can change the things on the right-hand side. Obesity I talked about, physical inactivity I talked about, diet I talked about, random high blood sugars. And then insulin resistance is by and large not inherited. It's by and large created by the factors above that. And impaired insulin secretion, we can improve that. We have medicines that can actually make that better now. And so we would like to fix all these things on the right before you actually get diabetes. In spite of the fact that we know that pre-diabetes leads to diabetes, no insurance company will pay for anything involving pre-diabetes. You can't get a diet consult, can't get diabetes education, can't get anything paid for if you only have pre-diabetes. They want to make sure you really have diabetes and then try to fix it after it's already too late.
Is that true for Medicare too?
It's absolutely true for Medicare. It's more true for Medicare than other insurances.
Oh.
If you go to referral to the Gecko Diabetes Center, which I run, for the diagnosis of pre-diabetes, cash only, Medicare won't pay. So we have to fudge around it. So it gets into the question of what's Medicare fraud. So we write on there you have hypertriglyceridemia or hypercholesterolemia. Then you can go be seen for the other diagnosis that goes with pre-diabetes, but not just for the pre-diabetes by itself. Doesn't make any sense, but there it is. So this is the correlation of weight and risk of type 2 diabetes. So men in blue, women in red. You can see as your body mass index goes up, your risk of getting diabetes goes much higher. So ideal body weight is less than 25 BMI. All right? Dr. Green has an ideal BMI. I don't. I'm a little over that. I'm at about 26 or so. But you can see how fast it goes up once you get into that overweight category, in the 26 to 30, and then once you're above 30, it goes up exponentially, really out of control. So, what leads to high blood sugar? We have all these little organs thrown in here. At the top is the pancreas. So again, if your pancreas doesn't make enough insulin, you're going to have high blood sugar. On the right-hand side is the gut. So if you eat too much, put too much sugar into the system, too much carbs in the system, you stress out the rest of this system. So you really can have a big impact over on that right-hand side. In the lower right-hand corner, looks like a bunch of fried eggs, but it's meant to be fat cells. And that's a muscle cell, that red thing. So you need to take up glucose, sugar, into your fat cells and muscle cells to clear it out of the bloodstream. Every cell in your body needs glucose, needs sugar to stay alive, to metabolize. And you have to get the sugar out of the bloodstream into these cells. This requires insulin for muscle and fat cells. If the insulin isn't high enough or doesn't work, all that sugar stays in the blood, doesn't get to the cells where it needs to go. This leads to high blood sugar, dehydration, leads to muscle cramping, and wasting away, because you can't utilize the sugar that you actually have in your body. This is a liver over here. It's not a snail. It's actually a liver. If you have insulin resistance at the liver, your liver gets the wrong message. It thinks that you don't have enough blood sugar in your bloodstream because it's not getting this message. So the liver is manufacturing glucose and throwing it back into the bloodstream even when the blood sugar is high. This is classic for type 2 diabetes. So not only is your blood sugar going up because you eat too much, you can't clear it, but now you're making too much of this all at the same time. So it's sort of a triple whammy as to why the blood sugar goes up. So we can attack all these different areas. Now at the top here is something called an incretin. I'll come back to incretins in a minute. So this is a cartoon that appears in every diabetes lecture that I give, which gives you an idea of the progression of diabetes from normal to full-blown diabetes. And it's pretty much true across the board. So the first thing that happens is that insulin resistance goes up because you've had bad lifestyle function, your weight goes up, your intra-abdominal fat increases, and the insulin works less well. So this occurs early on before the glucose goes up. This is the people who are just overweight, insulin resistant, but not diabetic. And once it reaches its maximum, it doesn't change. What causes the hyperglycemia is the failure of the beta cell, the pancreas, to match this insulin resistance. So early on, the first thing that you see that changes is the post-meal blood sugar goes up.